Hello, I'm here. Hello.
Hi, Margarita.
Hi.
Welcome. Welcome.
Estoy...
I think we're going to have a good number of people this one. You know, the last conference was about 30 to 40, which is a good size. It's a very workable group. I'm happy if there's 20 people. It doesn't during these webcasts, you don't have to have a lot.
Yes.
See, I get nervous because right now I see like 5 people. I go, oh man, no one's going to come. But then usually always it starts filling up at the end. Do you know what I'm saying, Margarita?
Ahora son las 2:37 de la madrugada.
Okay. You didn't hear what I said. I asked something else. That's all right.
Yo trabajo 24 horas.
Oh, really?
Really?
Wow. Well, you were just sick, right? You were just home. I mean, in the hospital, right?
Yes, I'm in my house, but I have pain in the spine and pain in...
Sciatica, right? Sciatica.
Yes. And tomorrow there is only the Cuban, or there are
China a las 2 de la tarde.
Okay.
En Madrid.
En Madrid, sí.
En Madrid. Y otro de Cuba a las 6.
6. Sí. Estoy trabajando mucho ahora a esta hora por la noche. Voy más deprisa que por el día.
¿La noche?
Sí. Ahora más deprisa que a las 10 de la mañana. Trabajo mejor por la noche.
Oh, sí, tú.
Sí. Por la noche.
En su casa.
Sí. Por la noche despierta. Por el día.
No, demasiado ocupado. ¿No?
Sí, ahora estoy aprovechando para hacer cosas. Ya he actualizado la página web del curso. Ya he puesto el programa. He hecho muchas cosas. Doctor Bennett,
Yes.
¿qué más necesita usted que le envíe para empezar a promocionar mañana el curso? ¿Qué documentos? ¿Qué le tengo que enviar?
Yo tengo banner, información, tú tienes horario. Necesita descripción de su congreso allá. ¿Ok?
En el programa,
Sí, parte de los Wednesday, jueves, viernes, sábado, o parte de estas charlas. Tú quieres atraer personas para ir al hospital, ¿verdad?
sí.
Para un
Todavía,
laboratorio, ¿qué es? O para charlas.
laboratorio, charlas. La próxima semana le enviaré el banner de las charlas
Okay.
con el link a Zoom y todo que usted me dio. Pero para las charlas estoy esperando que el doctor Lawton y el doctor Morcos respondan, que ya les hemos escrito, por fin ya se lo ha enviado el doctor.
Okay.
Entonces, como ellos son en charlas, no les he puesto en el programa del curso de venir a España. Si quiere, revíselo usted cuando pueda y me dice lo que le tengo que incluir, lo que quiere que le envíe.
Okay. Sí, necesita ver cuánto trabajo necesita hacer para laboratorio.
Vale, ok.
¿Y tú necesitas mandar un cheque de depósito?
¿Que le envíe un cheque de depósito?
Sí, necesita mandar un depósito.
Yo a usted.
Sí, sí, cuando yo determino el precio total, tú necesitas mandar el 50% por PayPal, como ha hecho antes, ¿verdad? ¿Tú usas PayPal antes? ¿O?
No, el año pasado le enviamos una transferencia bancaria.
¿En dónde?
A usted el año pasado le enviamos una transferencia al banco.
Ok, hago lo mismo entonces.
Pero lo hicimos el último día del curso que es cuando me puedo sentar con el doctor, porque ahora me es difícil reunirme con el doctor, siempre está ocupado.
Sí, pero su mande el depósito hace un año. So, hago lo mismo.
No, el año pasado le pagamos todo completo.
Oh, sí.
Sí, luego le busco la factura si quiere mañana y se lo envío.
Ok.
Pero no se preocupe que le vamos a pagar.
Oh, sí, sí, yo sé. So,
Lo difícil es que pueda encontrar al doctor para hacer la transferencia.
sí, pero tú conoces este problema.
Sí, yo conozco.
Ujú.
Pero no se preocupe que pagar le vamos a pagar.
Es como hay un juego con niños. Ponga, ah, ponga algo en la cola de burro. Es un juego, ¿verdad?
Es un juego.
Burro está difícil para poner.
Sí, sí, sí. Yo sé que el último día me siento con él y le digo, tiene que pagar esta factura y esta y esta y esta. Pero antes nunca la encuentro.
Ok, aquí viene la gente. Nuevamente. Hola. Oh, this I.
John, can you hear me?
Hey, Ike, how you doing?
Hello?
Yeah, I can you hear me? Yeah, I can hear you.
John, you're muted. Can you hear
Oh,
me?
no, I'm not muted. Let me see if
Cannot
you're
hear you.
muted.
Cannot hear you, John.
Really? Really, like my microphone's
Hello?
on. Yeah, let me get you in here. I pulled on. It's funny. Can anybody else hear me? Ani, can you hear me? Cleaver? Hello, testing, 1, 2, testing. According to the board, I'm being heard. Can anybody
Hello?
hear me? Hello, can you hear me? Can anybody, Margarita, can you hear me?
Yes, I can hear you. John, I can
Oh.
hear you.
Okay.
Sí, sí, yes, pero,
I'm ready whenever you guys are, John.
Okay, just a couple minutes, okay? Yeah, we have lots of time, however much you want to use. There's Marvin. Marvin está allá. Hello, Marvin. I think Marvin's going to moderate. Or Honey, do you have a camera? Haney,
Sí, doctor, sí.
do you have a camera?
Sí.
Yeah, just 1 second.
¿Ves?
Muchacho, una vez.
Hi, Marvin or Honey, Haney?
Buenas noches.
Oh, okay, Marvin. Está allá. ¿Cómo estás?
Bien, bien.
Tú
Bien,
conoces, déjame introducir a Iberian. Probablemente tú no conoces, ¿verdad, Marvin?
Sí, sí, lo había visto.
Oh, tú conoces, you know Marvin,
Lo conozco en...
you're mute, go ahead.
Yeah. Hello. Hello, Marvin.
Hello. How are you, doctor? How
Pretty
are you,
good.
professor?
Pretty good.
Welcome to our country, Nicaragua.
Yes, it's an honor for me. Someday I look forward to visiting you in Nicaragua. I have heard that it is a very beautiful country with lots of lakes and fantastic forests and everything. So I am looking forward someday.
Volcano.
Okay.
Marvin, I'll let you introduce Ipe, okay?
¿Cómo no? Sí, claro.
Okay, you're gonna, tú vas a moderar, okay, Marvin?
Sí. Está la doctora también. Está la doctora Janey Bolaños.
Ay, sí, sí.
Hola, doctor. ¿Cómo
Okay.
está?
Hola, hola. ¿Qué tal, Haney?
Muy
Ok,
bien,
honey,
gracias.
¿está listo, honey? ¿Dónde está su cámara? No puede ver, honey.
Ah, sí, es que no le he puesto.
Déjame ver. Oh, okay. Okay, honey. Yo voy a introducir a ti primero, okay? Y tú habla de los estudiantes, qué personas quieren atraer. No, solamente introduce a ti y después introduce a Marvin, okay? Marvin va a moderar y Marvin va a introducir a Ike, okay?
Ok, ok.
Okay, listo. Vamos a ready, Ike? Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Buenos días, estoy Dr. John Bennett, televisando de Miami Beach. Tenemos el placer de tener Nicaraguan Grand Rounds con huésped Cherian de India. Y déjame introducir primero la estudiante que ayuda mucho para arreglar esta charla, trayendo residentes en otras personas. Buenas noches, Hani, para introducirte y ya.
Buenas noches a todos. Mi nombre es Janey Bolaño, soy nicaragüense, soy residente del 5º año del Hospital Antonio Lenín Fonseca. Actualmente estamos organizándonos con los residentes para que cada día podamos introducirnos a las charlas y que esto sirva de aprendizaje para cada uno de nosotros. Es muy importante para nosotros tener ciertos conocimientos, qué es lo que hacen en otros países, y realmente esto es de mucho provecho. Buenas noches. Le doy la palabra a doctor Salgado. Mucho gusto, buenas noches.
Buenas noches, doctora Haney. Hoy vamos a presentar al doctor Sheran.
I'm sharing.
Sí, Live Sheran. Neurocirujano de la India, de amplia experiencia, el cual nos va a hablar sobre cisternotomía. Como sabemos, esta parte de la neurocirugía es de gran importancia porque es una parte que algunos quizás olviden, pero es importantísima porque tanto en las enfermedades hemorrágicas cerebrales como en otras patologías, la disección, la apertura de las cisternas aracnoideas es de suma importancia para darnos un espacio que el cerebro en determinadas patologías necesita para respirar. Yo recuerdo que cuando era residente hacíamos, insistíamos en esta parte del proceso neuroquirúrgico en las patologías neuroquirúrgicas y sobre todo en la hemorrágica. Recuerdo que hacíamos un lavado de las cisternas tanto con solución salina como con papaverina, ¿verdad? Para evitar el vasoespasmo. Entonces, dejamos con ustedes al doctor, al profesor de la India, Lip Chera. Go ahead, professor.
Thank you, Marvin. Thank you, John. It's an honor to be with you guys all. So I'm going to talk to you about something that we started 15 years back. It was in 2007 that we started, by accident, we started cystonostomy. So it's 15 years now. So now the world is slowly waking up to the possibility that neurosurgery for trauma may be better than normal neurosurgery. So I'm going to talk to you. I'm going to interact with you rather than talk to you. I don't want a lecture. I would like you to understand this concept. I would like you to ask me as many questions as you have on this concept. And I hope someday some of you may be able to visit us, and I may be able to visit Nicaragua, and I can be able to show you what this surgery means. So let us start right now. I'm going to share the screen. Are you seeing my shared screen?
Yes.
Yes, fantastic. So
Okay. You want to put it full size? Full size? Yeah. I don't know how you like to do it. Do you want full screen? Yeah, there we
yes,
go. There we go.
you can see this.
Yeah, full screen.
Okay, so few things. Number one, the biggest challenge for neurosurgery in the developing, so-called developing countries is trauma. And I also have to tell you something that I tell everybody, that the developing country mindset is a mindset, is not really physical. It is where we think we are something inferior to somebody else. It's a developing, we are developing. No. We, in India, in South America, in Africa, we have the maximum number of patients. And it is not that you need fancy tools for doing excellent neurosurgery. You don't need. Of course, you need the correct mindset where you can use the tools that you have to optimum effect. But third world is a mindset. If somebody has that mindset in the United States or in Europe, they will end up as third world in neurosurgery, although not third world in living conditions. So let me tell you, in Asia, South America, Africa, the biggest burden is trauma. And if we keep ignoring trauma as something that is secondary, something that is less important than aneurysms or skull-based tumors, we'll be losing out on a big chunk of our practice, and instead we'll be doing an unfair job to these trauma patients by doing a surgery which is more than 100 years old, does not have any documented benefits, and our young neurosurgeons will be missing out on microneurosurgery, which should be done in these cases for patients' benefit as well as to avoid our young neurosurgeons to go to some place in Europe and United States to stand there in a theater to see somebody opening cisterns. So here we are making that revolution slowly, where our young residents are already opening cisterns, already getting the brain to be lax on the table, and already be able to understand aneurysm surgery because they're opening cisterns. Now, the surgical management for traumatic brain injury right now is a 100-year-old surgery described in Theodore Cocker, described in 1901. And you know what he did? He did lumbar puncture, although we have Cocker's point for ventriculostomy. He did lumbar puncture to see whether the CSF pressure is elevated. Of course, if you do lumbar puncture in trauma, you will not have elevated CSF pressure. So what he did was, he said, if there is no CSF pressure, but there are signs of raised ICP, like bilateral 6-nerve palsy, signs of herniation, So he said, if there is no CSF pressure, but there are signs of raised ICP, then pressure relief must be achieved by opening the skull. We know that this is wrong. The premises, the conditions by which Cocker thought that you should open the skull itself is wrong. We know that the CSF pressure is very high, but it's not transmitted through an LP. So his premises, his assuming that CSF pressure is not high was wrong. So decompressive hemicraniectomy is based on a wrong assumption. But like anything which has stayed for 100 years, it is difficult to change because it's in your mindset. It is in your mindset. Because if your child wants a doll, they will choose a Barbie doll. There may be an equally or even better doll, but they will select the Barbie doll because Barbie doll is in their minds, right? So this is the same problem. We know that when decompressive hemicraniectomy started, there was no evidence, there was no study to support it. And even now, after 100 years, there's no really any studies to support it. That's the fun part of it. That's something that it is amusing for me that it was a study, it was a procedure which was started with no real evidence. Cocker made a wrong assumption and started a surgery. And even after 100 years today, there's no real evidence. If you can look at this, there is no real evidence. And you know why it survives? Because it's easy to do it. Any resident can do it. And second thing, trauma is an emergency. It comes at night, 2 o'clock. So no senior guy wants to put on the microscope and sit down and open cisterns or do microneurosurgery at 2 a.m. and then be ready for the aneurysm at 7 a.m. Most of the places, they say, trauma, no infrastructure, no microscope. Decompressive doesn't need anything. But is this an excuse for managing the largest burden in 5/6 of the world with a 100-year-old surgery? Wrong physiology, wrong technique, old technique, just because everybody is comfortable. Most of the private hospitals, I don't know about Nicaragua, but most of the private hospitals in Asia like decompressive because there are 2 surgeries. If the patient survives the first one, then he has to put the bone back. So there is 2 surgeries. And of course, there is a significant amount of hydrocephalus. So it is like a patient is hospital dependent, and the outcome, you know, all the studies that is being done, the outcome is not so great. People say, we have done some decompressive and the outcome is okay. These are patients most probably who did not need surgery in the first place. So every journal has studied decompressive. There's not much of a hope. This is why we want you to try and start microneurosurgery, like every other branch of neurosurgery has started microneurosurgery. I want you guys, you know, it's difficult for older generation to accept and change. Even for me, I've been in neurosurgery for 20 years now. Anything new, I will think twice about it before changing. It is normal. But I want the young people to understand that microneurosurgery is the future. If there is any future for neurosurgery, microneurosurgery is the future. Not only microneurosurgery, ultra microneurosurgery. Now we have the exoscope. We have the exoscope now, and we are pushing this to be 100 zoom. I will show you some surgeries later if we have time. I can show you. Remind me, I can show you some anastomosis or some aneurysms and the exoscope that we've done. Well, Can brain trauma benefit from microneurosurgery? That's our question today. Now, for that, we must know a few things. You know, in the base of the brain, at the base of the brain, there's 120 ml of CSF. You know, in the ventricles, it's only 20 ml. In the base of the brain, there's 120 ml of CSF. And this CSF is communicating completely with the brain all the time through the paravascular spaces, because there is the vessels from the base of the brain, they go into the brain. And around these vessels, there are these spaces called the Verschurovin spaces. This CSF at the base of the brain is always in communication with the brain, unlike the ventricular CSF. The ventricular CSF is a production phase. That produced CSF goes into the system, and the cisternal CSF is always in communication with the brain. This is something that you must know about. This is something that we talked about in 2007. We didn't have evidence that time. But in 2012, by the geolymphatic system, we had evidence. This is something that we proposed. And because I was in Nepal, we didn't have basic science backing. But in 2012, we were proven true. So this is it. You can see this is the subarachnoid space. This is the artery. Although it's blue, this is the artery. And from the subarachnoid space, the CSF goes through this space, the perivascular spaces, everywhere into the brain. What is the function of this? It is for cooling and cleaning. And we proposed this way back in 2010, 2011, but we had no evidence when we said, people said we are mad. But now it's accepted. It's a chapter in many textbooks. If you Google cooling and cleaning, you will get all our articles. Cooling and cleaning of the brain. Now, this is a diagram that we drew many years back. So this is the system. This is the vessel going in, and you can see that around the vessels, the CSF is going into the brain, and this helps in cooling and cleaning. Why is it important in cystonostomy? It's important because this CSF, if there is bleeding in this space, let us say there is traumatic subarachnoid hemorrhage, blood is a newcomer, and that blood is a newcomer at high pressure. I always say it's a newcomer at high pressure. So imagine this fills with blood. And what happens? The Verschurovin spaces are small, so the red blood corpuscles cannot go into the Verschurovin spaces. So what happens? The pressure here increases. All the CSF displaces into the brain. All the CSF displaces into the brain. Imagine you take a 1.5 liter Coke bottle and try to inject 100 ml another fluid, let's say water, into that Coke bottle. The pressure will be so high. It's exactly what is happening. The CSF is displaced into this, and the pressure goes very high. Okay, and in that scenario, when the pressure is high, if you open the top, the brain will just herniate out. That is what we are doing by decompressing. Answer is open the cisterns. The cisternal pressure goes down, the fluid comes back in. That's physiology. This is the basis of cystonostomy. If you have understood this, you have understood cystonostomy. Only thing is, how do we do it? This is our cooling and cleaning mechanism for, how does the CSF cool? That's because when we are taking breath, you see all the sinuses are there. The sinuses are lined with wet mucosa. When we take a breath, it is like putting a fan onto a wet cloth, and the sinuses are cooled, and the CSF is the largest collection of CSF, suprasellar cistern, is right in the middle of all these sinuses. It's amazing. And when the sinuses cool, as I told you, the sinuses are lined with wet mucosa, and if you have when you breathe, the sinuses is like putting a fan on a wet cloth, and the sinuses cool, the CSF cools, and this CSF is pumped into all the brain by the pulsatility of the vessels. And it's a cooling mechanism, an amazing cooling mechanism. We think we may get the Nobel for this proposal someday. Even if you don't get it, it's okay. The joy of understanding this, the joy of describing this was amazing. So this is the secret behind CSF shift edema. When you have bleeding into this space, the pressure goes up, and that increased pressure drives the CSF into the brain, producing severe edema. So this is our chapter in the Springer Neuro series. We explained CSF. We described it first with a radiologist from Spain, and then Hira has helped me to write it up in Intech as well. So when she was working with me, and this is our chapters. So as I told you, this is the CSF shift in traumatic subarachnoid hemorrhage. And people ask me, what about doing a ventriculostomy? It will not work because you see, the ventricles and the brain are not in communication. While the cisterns are the brain, are in constant communication. It's like two balloons connected, and if there is a tap attached to one balloon, you open that and both the balloons decompresses. But if there are two balloons isolated and you have one tap on one balloon and you decompress that, only that part will decompress. It is the same for ventricles. Ventricles don't communicate with the brain. So if you inject markers into the ventricle, you see what happens to the markers. There is very little markers inside the brain. You inject markers into the cistern, you see what happens. The Varsharovin spaces are lighting up, and the markers in 30 minutes is all over the brain. So when you decompress the cisterns, you are really decompressing the brain too, physiologically. You're not allowing the brain to herniate out like in a decompressive hemicraniectomy. You know, the interesting thing is you almost 130 ml of CSF goes into the brain, and you open a 13 centimeter defect, and the brain comes out almost 1.5 centimeter. It's almost the same amount of water that is gone in, CSF that is gone in. That is the amount of the brain which comes out too. It's strange. We are allowing that brain to herniate. So this is the Elif talking about how the CSF gets into the brain.
Actually does so along very specific anatomical structures. There's specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system for clearing the fluid and the liquid. Actually does so. So
can CSF shift be proved? Yes. So in Calgary, my friend Dr. Garnett and his Nepalese resident Sanju, they did an experiment on a mouse brain, and they proved CSF shift edema. We had only hypothesized it. They proved it. They showed that post-TBI T2 weighted hyperintensities increase, and according to our hypothesis, you had blood in the cisterns and edema in the brain, CSF shift edema. All the CSF had moved out. So this is a graphic representation. That is cistern, subarachnoid hemorrhage. So pressure increases and it goes into the brain, and you open the cisterns, and then you have the brain physiologically, the edema comes down. Okay. So the definition of cisternostomy is opening the cistern and letting out the CSF and causing the CSF shift edema to reverse, and thereby reducing the pressure in the paravascular spaces and the brain interstitium. So this is the concept of CSF shift edema. This is the sternostomy where you open the cistern. This is decompressive where you allow extracalvarial herniation. But how do we open the cisterns in a very tight brain? This is not easy. If you follow decompressive surgery, if you don't know about skull base, this is very difficult. But it's just pure skull base surgery. We remove almost a lot of bone in the base and then go to the base where the cisterns are and open right above the optic nerve, and you can get into the cisterns even in a tight brain. Aneurysm surgeons know that technique. Most skull-based neurosurgeons know that technique. That's just it. It's nothing big. It's just a matter of if you have aneurysm surgeons with you, you ask them in a very bad aneurysm, how do you get into the cisterns? They'll tell you. You go subfrontal and do a lot of skull-based work to remove all the bone and then get into the subfrontal space, and then you are into the cisterns. That is all. It's you just need to go to the lab. You can come to us as well. We will show you how to get into the base of the brain. And if you get into the base of the brain, you are doing cisternostomy. And not only for trauma, it can be done for pretty bad cases of aneurysm rupture. We recently had a very bad WFNS grade 5 aneurysms. I mean, we had 2 of them. And we opened the cisterns and brain was bulging out. We opened the cisterns first. Now, for every aneurysms, we open the cisterns first and let out the CSF, and the brain goes completely lax. And after that, the aneurysm surgery is much more easier. So to open the cisterns in skull base, there are a few unlockings that you need to know. So the brain is in this way. So if you remove this part, that is the sphenoid ridge, this is called sagittal unlocking. Also, sometimes to get into the interpedunculaire space, you need to peel this temporal lobe away from the cavernous sinus. It's called the transcavernous dissection or the pericabinous dissection, taking the temporal lobe away. This all is not needed in cisternostomy. I was wrong because when I was a pure skull-based surgeon, so I started doing all this, and my colleagues all over the world proved that there is no need, just a little tyrannical craniotomy, a lot of bone drilling in the sphenoid ridge, and just going subfrontal is enough. So, but my presentation carries all this because I'm trying to analyze how we get into the cisterns. So I call it unlocking, but this is pure skull-based surgery. Don't worry about this. You really don't have to follow this, but if you're interested, if you have questions, I can answer this. So sagittal unlocking is just taking off all the sphenoid ridge, okay? Axial unlocking is just taking the temporal lobe away from the cavernous sinus, slowly preserving the true cavernous membrane, and therefore you can get into the interpedunculaire posterior part of the suprasellar cistern also. So basically, what you're doing is, this is a temporal lobe like that, orbitomeningeal band is like that, the frontal lobe is like that. So you cut the orbitomeningeal band and see the frontal lobe, temporal lobe now. You can get into the cisterns very easily now. I can someday show you in Nicaragua, if you have a kind of a workshop, and I can show you the modified Dolenz approach, which we propose. And it is not really required for cisternostomy, but if you know about it, it's a good thing for your skull-based and vascular cases. Again, anterior clinoidectomy is not really required for cisternostomy, but sometimes in tight brains, very, very tight brains, if you want to open the opticocarotid window, it would be good if you can remove a little bit of clinoid also. And so those are the dissections, the transcavernous dissection, the temporal lobe is being taken away from the cavernous. This is the clinoid process. This clinoid process is removed. That's carotid after you remove the clinoid process, the C3 segment. Then you're opening at the base, the standard smalls, opening at the base for cisternostomy. And then you have going into the base, you see the optic nerve and the subfrontal root to the optic nerve and the carotid. And that is a posterior clinoid. Sometimes I used to remove, but there's no need for that also. And after you open the membrane of Lilliquest, you can see the P1 segment. The carotid is here, the optic is here. And that is it. You can see one video. This is under, I operate under very, very high magnifications. You will get used to this. I mean, all the young residents, I will advise you to start operating on the highest magnification that you're comfortable and keep increasing it. It's like going to gym. Today, if you're comfortable with 20 push-ups, you have to go to 30, 40, 50, and finally 100. And you should not stop at 100. You should never get comfortable. You know? That is the secret of constant improvement. So here we are drilling off the sphenoid ridge. And after that, this is nothing much. I mean, we are not doing any transcavernous dissection or anything here. Not much, a little bit of it. And I'm going to open, I'm taking off the sphenoid ridge, and the clinoid process, lateral clinoid process. After I dissect, I open the orbitomeningeal band. It's very easy for the clinoid process to be taken out. I can use it, I can take it out with just, break it out with just a needle holder and take it out because I'm opening the orbitomeningeal band. You see, I can see it very clearly. And once the clinoid process is taken out, I have space and now I'm opening the brain. You see the damage in the brain. Once you open at the base, so there's a temporal lobe which is really damaged. So that's optic nerve, that's carotid, that's A1. So that you are going to the membrane of Lilliquest. There's so much blood in the cisterns. The temporal lobe was herniating over the optic and over the carotid here. Not only over the third nerve, but over the carotid. This is a temporal lobe. And once we've opened the basilar, the membrane of Lilliquest, you can see the basilar very clearly. There are a few perforators here. You have to be careful with that. This is not something that will take a learning curve of more than 1 year. In 1 year, if you have passed neurosurgery and if you know how to handle the microscope, in 1 year, you will learn this. So we have many fellows with us. Right now, we have a fellow from Peru with us. We have from Italy, we have from Africa, we have from Russia. So they all come and within 1 year, after the dissections and everything, we get them to learn how to open the membrane of Lilliquest. They see many cases and then they are okay. And we open all that arachnoid and define the basilar. You see, if you can do this in trauma, you can do this for an aneurysm. It's very simple. So anybody who tells you clipping is difficult, no, once you have done enough cystinostomy, we have over 1,500 cystinostomies documented, maybe much more than that. So over the last 15 years, maybe much more than 1,500. And our colleagues in South America, colleagues in China, Central Asia, India, they have much more. Many publications are coming out right now. Well, some of them, they follow different techniques. Some of them don't go. Now see the brain, which is really lax, okay? It was not at all like that to begin with. See the injury in the brain, okay? Terrible injury. You easily keep the bone flap back here. There's absolutely no problem at all. So the indications are almost the same as for decompressive hemicraniectomy. We have an indication score and the interpretation of the indication score. It's all published in World Neurosurgery. And contraindications are when there is increased age over 80, hemorrhagic diathesis. This is a complete no-no. If you have a bleeding disorder, then it's not good. We've had patient, maybe 1 month back, we had a bad patient with a bleeding diathesis, and it was not good. We had bad results. So bleeding diathesis is not good. Systemic complications, polytrauma, isolated diffuse axonal injury, prolonged severe hypotension, that's bad. Prolonged hypoxia, this is bad. And well, the clinical outcomes, see this is one of our first cases. Okay, see the amount of edema here. All right, no cisterns seen. This patient, this is 4M2, and it was almost 11 years back maybe. And this boy presented to us with the M2 response, and that time we were doing a decompressive along with cystonostomy. But we had started, in 5 years, we had started to put a thin bone, take out a lot of temporal bone and then keep a thin bone over there. This is how we evolved in cystonostomy. So you can see that that thin bone is kept. You see that thin bone is kept there, but all the cisterns are open. Okay, there is still a lot of damage, but this boy went walking back. I hope I have the video of this boy walking back. I can show you someday. He walked back. Okay, he's doing a job. See this one. Okay, this temporal lobe is herniated. You can see the herniated temporal lobe here. You can see the herniated temporal lobe here. Very, very bad. Okay, so much midline shift, edema, and interparenchymal hemorrhage. See the guy, we've just taken the, opened the cisterns, and he's in the ICU sitting up. Okay, so if you didn't decompress your hemicraniectomy, I don't think he would ever sit up. There's another one, very bad. This patient was heli lifted to us and was related to the football captain of Nepal, his relative, so it's heli lifted to us. Very bad patient, many years back, working now. Okay, so M4 response to start with. This is the post-op. Another one, very, very bad. You see, there is so much edema. This patient was bilateral fixed pupil, E1, V1, M2, such bad, so much bad that you see, to get into the cistern, we had to, retract and reach the cistern. Once we reached the cistern, we could keep the bone flap back easily, even with that kind of edema. And this is the patient, and she's a working housewife. It's not like a decompressive where she's dependent on all her family. Another one, so you can see the edema and the subdural hemorrhage. She deteriorated, and this is it. Keep the bone flap back, and she's in the ICU. She comes to my room walking. So like that, we have so many of these. So this is from Europe. They showed how the ICP dropped from 48 to 11, and skin to skin, 65 minutes, done by Jiri from Czech Republic. So many of these cases from all over the world, anatomy, and give me a second, guys. I have a call from the hospital. 1 second. Hello. ഞാനൊരു ടോക്കിലാണ്. പറയൂ എന്തെങ്കിലും കാര്യമുണ്ടോ? ഇല്ല, ഞാനൊരു നിക്കരാഗ്വൻ സൊസൈറ്റിക്ക് ഒരു ടോക്ക് കൊടുത്തിട്ടുണ്ട്. കഴിഞ്ഞിട്ട് ഉടനെ വിളിക്കാം ഞാൻ. So these are the publications on cystonostomy. Initially the big journals don't allow you to publish anything out of the ordinary. So because they're peer-reviewed journals, and the so-called reviewers have absolutely no knowledge of new things. And when they don't have knowledge of new things, they just reject it. They only accept. That's why neurosurgery never progresses sometimes. New things, if you put it in front of somebody who's an expert, so-called expert, because they're supposed to be experts and they don't know about it, they'll just reject it because it's easier for them to reject rather than saying that I don't know about this. So these are the publications. Slowly, we went from one journal to another. This is in the Asian CNS journal, AJNS journal. And then others experience. Then World Neurosurgery. So this is from Lausanne, Switzerland. Their trial on cystonostomy. And these are their articles from Lausanne. So many articles. And some people have now started it for early infarct after the window period for intervention has gone. But before the diffuse edema has set in, they have started cystonostomy and they've got fantastic results. I have no experience with infarcts, but the Massimiliano's group there, and these are the papers which support CSF shift edema. So if you ask me, can neurosurgery benefit from microneurosurgery? Yes, for sure it can. Thank you very much. And I'll be very happy to take any questions that you have. This is our farm in Nepal. We still keep it, although we can go only there once in a year or so because we are right now in India. And India also, this place is beautiful. We are on the Western Ghats, a lot of mountains and lakes and waterfalls. So anytime you would like to come, we welcome you here. And if you have any questions, please go ahead and ask me. I'd be very happy to answer. And stopping the share. And if you want to see any other surgeries like STMCs or aneurysms or skull base, if you want any videos, I'll be happy to show them too.
Thank you very much, Professor. We hope you will be back in other conference to us. Si alguien del público tiene alguna pregunta para el profesor.
Sí, Ramón Valera tiene pregunta.
¿Hay alguna
Marvin.
pregunta?
¿Se puede ver la pregunta de Ramón Valera en el chat?
Había una pregunta de Venezuela. Que ¿En qué momento?
Exacto.
¿Cuál es el momento ideal para la cisternostomía? El momento ideal para la cisternostomía.
When is the ideal moment for cysternostomy, to do a cysternostomy? What's the ideal moment?
Yes, 1 second. So unlike decompressive, the cystonostomy is not a surgery that you wait for a long time and then wait for medical management to fail and then do cystonostomy. No. Cystonostomy is a proactive surgery, which means that if the patient has severe swelling, midline shift, and if the patient is dropping GCS, or if there are some other indicators, like for example, the CP angle system is widened. This means that the patient is going to herniate. Why the CP angle system is widened? Because the temporal lobe goes and pushes the midbrain away. So when the midbrain is pushed away, the pons is also pushed away. So when the pons is pushed away, the distance between the pons and the petrous bone increases. So this shows on CT as widened CP angle. And we have published a paper saying that widened CP angle is a very, very important indicator for cystonostomy. So like that, if you have mass effect, midline shift, widened CP angle, absence of cisterns, we have a paper in NEJM saying that if there is absence of cisterns, that means that the pressure is definitely about 25 millimeter mercury. So you know that if there is absence of cisterns, if there is CP angle cistern widening, if the patient is dropping GCS, if there is massive midline shift, if there is mass effect, all these cases we don't wait. We don't wait for the ICU expert to give mannitol, to give decrease the ventilation, to freeze the patient, or some measures like this. We don't wait. We just go in, operate straight away. So this is the ideal moment is immediate.
Okay. Don't be afraid to ask questions. He's here now. If you
May
have any questions, go ahead.
I speak?
Yes, please.
Okay.
Doctor Lazo,
Nice to meet you, Dr. Shirian. In behalf of all the Nicaraguan neurosurgeons, I would like to thanks for sharing your knowledge with us. I would like to ask if there is any surrogate for cysternotomy, because as you said before, in our country, it's a development country, and so we don't have the night shift and microscope. So if the CSF release from the basal cistern could help at the moment for help to help the patient to get a better outcome after the surgery.
You are saying you don't have a microscope.
Yeah, we do. We have, but usually we use the cape that we use. We only have one or two, and we use it during the surgery, the scheduled surgery for the day. So if we use it during the night, we don't have how to dress the microscope during the day. So if there is any surrogate to perform it, or only we could do it with a microscope.
Yeah, so no, other than a microscope and exoscope, I don't think with a loop you can perform a complete cysternostomy. With a loop, you can open the anterior, this is called anterior cysternostomy. You can open the opticocarotid cisterns, but the membrane of Lilliquist, you will need the microscope, because we have tried opening with the loop. It's difficult, and it's dangerous, because you don't get the correct magnification at the depth or even the correct lighting. So I would definitely ask you to use the microscope. I know that in many hospitals, they don't use microscope for trauma, but this is a mindset that I want to change. Maybe you should have a microscope for trauma as well. And after opening the anterior cisterns, the opticocarotid, the brain will be a bit more lax, but if you close with that, there can be rebound edema. Even with the brain, there can be rebound edema. So you have to open the membrane of Lilliquist, because when we were doing anterior cysternostomy, at least 1 in 4 patients, we had to take it up and do decompressive again, because it was rebound edema. It was brain would go down at that time, but after the membrane of Lilliquist is not opened, the brain goes into edema again. So I want you to open the membrane of Lilliquist also, but with a microscope. And we have now randomized control trial from India done. We have many studies from Europe, including Lausanne. There is a study from India where comparative study, retrospective comparative study in the NSI journal. There is one from Europe, there is one from China, there is a randomized control trial from India. So there are many studies now showing the results are better. So you can follow them, and then maybe I hope you can change to starting the microscopic trauma.
Yes, there's someone on the panel, Claver. He's a med student from Cuenca, Ecuador. He's asking about the fellowships and I know you have fellows that come over there for periods of a month, 2 months. Can you please describe that and maybe show some pictures of the fellows you have over there?
So we have at the moment we have a fellow from Africa. We have a fellow from Africa, we have a fellow from Italy, we have one from Peru, we have 2 from Russia. But we had in the past many fellows from all over the world. I mean, while we were in Nepal and India, we had many fellows. We take these fellows as observers, and if they are neurosurgeons and they have registration in their own countries, we can allow them to operate also, because we can get a temporary license for them. But if they are medical students, it's difficult for us to get them to operate, but definitely they can scrub with us for minor procedures. although independent or even supervised surgery will be difficult, but they can come to the lab. We have an Esculap lab, the first one in maybe Southeast Asia. So we have an Esculap lab with microscopes, everything. So we have regular courses every 1 month or 2 months. We have courses in skull base and microvascular anastomosis and epilepsy surgery and things like that. So we have a course on January 26, 27, 28, and we have another course in March. We have another big course in August. So as we also help people to understand the differences between microscope, exoscope, and endoscope. So for example, right now, we are operating with, as I said, we are operating with the exoscope right now. So we are finding it's way better than actually a conventional microscope, and we are trying to fuse virtual reality, navigation, endoscopy, exoscope all into one instrument. All these technical things you can see if you come here, and you are very welcome. Anybody who wants to come can be my guest. So you just write to us. John has my WhatsApp number. So you just write to me that you want to come, and you come here. We will be very happy to host you.
Yeah, the WhatsApp group you have, Ip, is Neurosurgery Coach, right?
Yeah, yes, Neurosurgery Coach.
Yeah, if you guys want to join, just go to Neurosurgery Coach.
Yeah, so plus you can give my WhatsApp number on the message window, and they can contact me directly, and I can get them in touch with my fellows, or I can answer them and then tell them how to come.
Okay, any more questions? Ani
¿Hay alguna
Velados?
pregunta?
Go ahead, Marvin.
¿Hay alguna pregunta más para el doctor Light Chire? ¿Hay alguna pregunta más? Que realmente es un tema muy interesante, muy importante, porque la cisternostomía, la apertura de las cisternas, en muchas ocasiones hemos visto que han salvado vidas. Han salvado vidas porque es una forma de descomprimir al cerebro en diversas patologías que comprometen la vida.
Marvin, yo tengo una pregunta. ¿Tú has hecho una cisternostomía antes, Marvin?
Sí, muchas veces, muchas veces.
Oh, okay.
Sí, muchas veces, many times.
Los residentes.
Muchas veces, sí, sobre todo en patologías hemorrágicas, en las que en patologías, aneurismas cerebrales rotos, en las que había que ir en las que hay que lavar las cisternas basales, y sobre todo cuando yo era residente la hacía con solución salina y papaverina, un lavado.
Okay. Normalmente durante residencia se enseña cisternostomía en su residencia de neurocirugía en Nicaragua.
Claro que sí, claro.
Okay.
Claro que sí, sí.
Okay.
Eso está dentro de la...
He's saying it's common for them to teach cisternostomy during a residency.
Yeah, so we'll be happy to do that. I mean, we'll be happy to invite them over here and give them exposure to cisternostomy so that they understand it is not very difficult. And once they go back, now the African resident, African neurosurgeon who's here is going to be here for 2 months. He's already doing microscopic surgery. He has seen 2 or 3 cases now, and by the end of the month, he'll be ready to go back and start.
¿Hay alguna pregunta para el doctor? Doctora Hani.
Ok, hay un pregunta de Ramón Valera. ¿Tú puedes verlo, Marvin? ¿Puedes leerlo, por favor?
Sí, ya contestó la pregunta del doctor.
Es una pregunta nueva. ¿Cuál es? ¿Tú has visto esta pregunta antes de Ramón Valera?
Excuse me. Ramon Valera is asking if which is the size of the craniectomy for the cisternotomy, and if the lumbar drain is useful for the cisternotomy.
Okay. So the site depends on the side of the subdural or the condition or the side which is affected maximally. But if there is diffuse brain swelling, I generally go on the right side. And from one side, you can open the cisterns, the optical carotid on the other side. Also, once the brain relaxes, you can open the cisterns on both sides. So you don't need to go to the other side if there is diffuse edema. So it is usually one side is enough. And the second thing, lumbar drain, if you have high ICP, if you put in lumbar drain, it can cause herniation syndrome. So maybe lumbar drain is not a good idea. I prefer to do a cystonostomy. And sometimes what happens if earlier we used to put smaller tubes, and if it blocks off, already the brain is lax and I can put in a lumbar drain. But generally, no, not lumbar drain. I mean, cisternal drain. We use the cisternal drain.
Okay, Ramon
Thank you
Valera.
so much.
Go ahead. You have another
Thank you
question?
No question. Just say thank you, doctor. It's very important to share the idea for the residents that are in the presentation, because in Nicaragua, in the hospital that grow the neurosurgeon in Nicaragua, we do the cysternostomy just in hemorrhage, like aneurysmatic hemorrhage, not in trauma. But this is very good presentation, because we have to change that idea that use this cysternostomy just for the subarachnoid hemorrhage because aneurysm. Thank you so much, doctor.
Very much. Okay.
Okay, Ramon Valera, a resident from Venezuela, asked, what is the size of the craniectomy to make a cysternostomy?
I didn't answer.
He already answered the question.
Oh, I'm sorry. Okay. Okay, I'm sorry. Okay, and no question is too small or too insignificant. If you haven't had experience with cysternostomy, it's open.
I have just given my number in the chat to Dr. Clever, and also I put it in my chat right now, so maybe I can, if there is any question, so I can ask you to please contact me on WhatsApp. So I am I'm giving my WhatsApp number also, so that if you
Yeah, let me just put the name of that WhatsApp group, Neurosurgery.
yes, coach as well. So this is my WhatsApp number I have shared with everybody. So you have questions, you can ask me. And it's been an honor to be talking to all of you. Thank you very much. And I hope to come someday. I am in Mexico from October 31st to maybe November 9. I am in Mexico. I will be in Cancun for their National Congress. And also I will stay some other days to interact with my residents and my fellows, and maybe do some help with some surgeries of cystonostomy. So if anyone of you would like to come, you're most welcome to come to Mexico and meet us. And I hope in the coming years I can come to Nicaragua as well. Thank you very much. See you guys.
We hope to be able to televise you from Mexico City.
Yes.
Thank you, Professor Light.
Yeah.
Yes, and we're going to, you're going to excuse me, we're going to invite you to televise to Venezuela also. We just got to work out the time.
Yes.
We'll go country by country, right?
Yes, yes. I had two residents, fellows from Venezuela 3 years back, and they were very good. Juan and Eugenio, both of them helped me a lot.
Eugenio, right?
So
Eugenio Cerezo.
yes, Eugenio Cerezo. So they were there.
And there's one in Peru. What's the gentleman's name? He's
Edmundo Valencia Bayona. He was supposed to present today, but all the fellows have gone for some mountain cycling. So I will join them after this. So I will do a presentation and I will go join them.
Okay, thanks for your time, and we hope to have you back soon.
See you guys. See you. Thank you very much.
Bye-bye.
Yeah. Okay, Mark.
Okay, we stop.